There's a photograph in the National Archives from 1889. It shows the grounds of the Utica State Hospital in New York. 1,100 people standing in rows in front of a Gothic building, so large it disappears into the frame. Not all of them are patients. Many are staff. But the building itself is what matters. It is 5 stories tall. It covers 4 city blocks. The architecture is deliberate, designed by Thomas Kirkbride, the asylum superintendent who revolutionized institutional medicine in America. The design was supposed to be healing. Long hallways with windows on both sides. Wards arranged in a radial pattern like spokes of a wheel. Everything oriented toward the idea that architecture itself could cure mental illness. Moral treatment. They called it. The theory was simple. Remove the afflicted from society. Put them in an environment where every detail, the light, the air, the geometry of the space was designed to restore sanity. It worked well enough that by 1890, America had over 1,000 of these hospitals. 1,000. In a country of 60 million people. The largest employer in most counties where they were built. The photograph from Utica shows what peak capacity looked like. By 1910, that building was half empty. By 1920, it was a shell. By 1960, the patients were gone. The buildings remained. They remained because they were made of stone. They remained because nobody knew what else to do with them. What they did not explain is what happened to the people. The numbers are worth holding for a moment because they do not sound real when you say them quickly. In 1890, American state mental hospitals held approximately 150,000 patients. Not private facilities, state institutions, public asylums. Some of these buildings house 5,000 people. The Danvers State Hospital in Massachusetts, the Kirkbride in Pennsylvania, the Willard Asylum in New York. These were cities unto themselves. They had their own farms, their own power plants, their own burial grounds. Most asylums in operation by 1890 had been built in the previous 40 years. This was not an ancient system. This was the cutting edge of 19th century medical thought. The Kirkbride Plan, the architectural model these hospitals followed, was based on a theory of healing so specific that Thomas Kirkbride wrote a manual about it. 500 pages of text devoted to window angles and hallway widths and the proper proportion of male to female wards. He believed that if you got the geometry right, if you got the light right, if you got the air circulation right, the building itself would heal. It did not work, but it was tried with total conviction across 30 states. The institution spread across America like a grid, one in every significant population center. Some were built on the outskirts of towns. Some were built in isolated valleys. All of them were enormous. All of them were full. What caused a surge in admissions? The official narrative points to the Industrial Revolution. Urbanization caused mental illness. Factory work caused mental illness. The pace of modern life caused mental illness. That is partially true, but the admissions numbers suggest something else. They suggest that asylums were catching everything society could not categorize. A woman who refused to marry, a man who drank, a child who would not obey, an immigrant who did not speak English. A person whose behavior fell outside expectation was put into a hospital, not always for violent reasons. Sometimes simply because there was nowhere else for them to go. The institutions became catch-alls, medical facilities that operated as orphanages, poorhouses, prisons, and actual hospitals simultaneously. By 1895, the largest asylums were operating at triple capacity. Patients were sleeping in hallways. Ward designed for 50 people held 200. The healing geometry of Kirkbride's design meant nothing when you were 3 bodies deep in a room built for 1. Something had to give. The system could not sustain itself. The budget could not sustain it. The building capacity could not sustain it. The institutional machinery would have collapsed on its own momentum. But something else happened first. In 1906, a man named Clifford Beers published a book called A Mind That Found Itself. Beers had been institutionalized. He wrote about his experience. The book was not kind to the asylum system. It was not kind to the treatment. It described abuse, neglect, patients left in filthy wards for months. The book became unexpectedly famous. It created a movement. Mental hygiene, not the architecture, not the Kirkbride design. The actual treatment of human beings. It was a simple idea, but it was revolutionary because it suggested that maybe the problem was not the patients. Maybe the problem was the institutions. At almost exactly the same time, a parallel shift was happening in medical science. Freud was publishing. Psychology was becoming a discipline. The idea of talking to people about their problems rather than institutionalizing them was gaining traction in certain circles. The very institution that America had built across 30 states, the asylum, was becoming philosophically suspect at the exact moment it was physically overcrowded. Between 1906 and 1915, state legislatures across America began passing laws enabling the discharge of chronic patients. Not recovery based on medical assessment, just discharge. The assumption was that if you had been in a hospital for more than 5 years with no improvement, you could be released back into the community. The logic was not humane. The logic was economic. The hospitals could not afford to keep you. The state could not afford to keep you. You had to go home. What happened next is not well documented because the documentation was either not kept or was destroyed. The discharge records from the major asylums of this period are incomplete. Some hospitals burned. Some records were classified under medical privacy laws that existed at the time. Some were simply lost. What we know is this. Between 1915 and 1925, the patient population in American state mental hospitals dropped by approximately 40%. Not gradually, in waves. Entire cohorts of people released back into communities that had no infrastructure to support them. No follow-up care. No housing assistance. No family notification in many cases. Just the gates opening and people walking out. The photographs from this period show something interesting. The hospital buildings themselves do not change. The architecture remains. But the grounds empty. The photographs of hospital staff shrink. The photographs of patient work details disappear. By 1920, the largest asylums in America were operating at 40% capacity. The beds remained empty. The building stood. The machinery of institutional medicine ground on, but it was grinding on nothing. Where did the patients go? The discharge records do not say. The follow-up studies do not exist. Or they exist but were not published. Or they were published in journals that no longer maintain archives. The paper trail ends at the moment of release. No notation of where people went. No record of whether they survived. No census data that tracks what happened to the 100,000 people discharged from American asylums in a single decade. The timing of this emptying is worth examining because it overlaps with something else. The same years that asylums are discharging patients in massive numbers, the orphan train system is winding down. The orphan trains operated from 1854 to 1929. Peak operation was 1875 to 1895. By 1910, the system was already declining. By 1920, it was nearly extinct. 2 separate institutional systems, one for children without families, one for adults deemed mentally ill, both operating at peak capacity around 1890. Both empty by 1920. Both with minimal documentation of what happened to the populations they held. The official histories attribute the asylum decline to medical progress. The discovery of pharmacological treatments, the development of psychotherapy as an alternative to institutionalization. These things are true. Chlorpromazine was synthesized in 1950. It did reduce acute symptoms. But the major discharge wave happened 35 years before that. The asylums were emptying decades before the medical technology existed to support community-based care. What documentation does exist suggests something else was happening. The patient discharges did not correlate with recovery rates. They correlated with bed shortages. They correlated with budget crises. They correlated with the shift in medical philosophy toward what became known as deinstitutionalization, the idea that institutions themselves were the problem, not the only problem, but the central one. Get people out of institutions, and they would get better. They did not get better. Most of them did not, but they were out. And that is what mattered to the system. By 1930, The asylum population had stabilized at roughly half its 1895 peak. The buildings remained. Most of them would remain for another 50 years. The Danvers State Hospital operated until 1992. The Pennis Asylum in Pennsylvania operated until 1987. Some are still standing. Empty, the architecture preserved, the function abandoned. The people who had been inside them scattered into a society that had no mental health infrastructure to speak of. What happened to 150,000 people discharged from state institutions with no follow-up care? Some went back to families. Some found work. Some ended up in the criminal justice system, which became the de facto mental health system of America. Some became homeless. Some simply disappeared from any institutional record. The outcome data does not exist because nobody was counting. The system had stopped needing them. The buildings could stand empty. The patients could vanish. The machinery moved on. The irony is that the asylum system failed not because it was cruel, though it often was, but because it tried to be complete. It tried to solve an entire category of humans suffering through architecture and institutional medicine. When that failed, when the patients kept coming and the buildings ran out of space, the response was not to improve the system. The response was to dismantle it, to release people back into the exact conditions that had driven them to the institutions in the first place. The Kirkbride buildings themselves are fascinating because they are still there. The architecture is so distinctive that Kirkbride Plan hospitals are recognizable by sight. The radial design, the long wards, the central rotunda. Some have been preserved as historical sites. Most have been abandoned. In the basements of the remaining active ones, there are sometimes files, patient records from the 1880s and 1890s, names and admission dates and diagnoses. The diagnoses are remarkable. Moral insanity, hysteria, dementia precox, masturbatory insanity. These were not medical categories we would recognize today. They were catch-alls for behavior that fell outside acceptable bounds. The records are filled with people admitted for what we would now call poverty, inability to find work, inability to adapt to industrial employment. The asylum was a place to put people who could not fit into the economy. When the economy changed, when the philosophy of institutionalization changed, the buildings were no longer needed. The people were simply released. Some historians argue this was progress. The deinstitutionalization movement was founded on genuine principles of human dignity, the idea that people should not be locked away for their entire lives. It was not wrong, but the execution was catastrophic. The community mental health centers that were supposed to replace the hospitals were never adequately funded. The supportive housing that was supposed to exist never materialized. The society promised to support people in the community could not follow through. So people ended up homeless instead of institutionalized, in jail instead of hospitals, dead instead of living. The outcome was not better. It was different. The Kirkbride buildings stand in cities across America. Most are abandoned. Some have been converted into condos for the wealthy. The very architecture designed to heal mental illness is now marketed as historic charm. The radial wards become luxury apartments. The patient day rooms become penthouses. The ground where 150,000 people lived out their confinement is now real estate. We have the buildings. We have the architectural plans. We have some of the patient records. We have the discharge statistics. What we do not have are the follow-up outcomes. The government never tracked what happened to the people after they left. Not systematically. Not comprehensively. And the reason we do not have that data is not because it was lost. It is because it was never collected. The system did not need to know what happened to them. Once they were outside the institutional boundary, they ceased to be the system's responsibility. The Kirkbride design was supposed to heal through architecture. It could not. No architecture can cure structural social problems. But the attempt to build a solution said something true. It said that we knew something was wrong. We tried to fix it with buildings and regulations and careful geometric planning. When that failed, we did not try something better. We simply let the people go. The buildings remain. The people scattered. The architecture was preserved. The human beings were not. The stones remember. The files remain. The names are documented. What we chose not to document was where those names went. And that silence says more about the system that released them than any statistics ever could.